Welcome to Treatment Strategies for People Who Use Fentanyl. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague Jeff Bornstein. Thank you to our partner for today's event, the National Overdose Prevention Network, a program of the PHI Center for Health, Leadership, and Impact. Let's meet the moderator of today's event, Dr. Carmen Rita Nevadas. Dr. Nevadas is the director of the PHI Center for Health, Leadership, and Impact, which runs the National Overdose Prevention Network, the director of Dialogue for Health, and the senior vice president emeritus of External Relations and Preventive Medicine at the Public Health Institute. Welcome, Carmen.
Good morning, everybody, and welcome. It's really very exciting to have an opportunity to share a conversation about fentanyl and people who are using fentanyl, and looking very carefully and in a broad way to see what kinds of treatment strategies and how we should be thinking about treatment with respect to people using fentanyl. I am really happy to be introducing our speaker today. Ariana Campbell is an emergency department physician's assistant with more than 20 years of clinical expertise informing her work. As an advanced practice clinician lead for U.S. Acute Care Solutions at Marshall Medical Center in Placerville, California, Ariana initiated an innovative program to treat patients with opioid use disorder. Recognized by leaders in addiction medicine and beyond, Ariana has become a founding clinician of California Bridge, a program of Public Health Institute. She currently serves as director and co-principal investigator for California Bridge, dedicated to making 24/7 access to addiction treatment for the standard of care for every hospital. Ariana presently serves on Marshall's Provider Advisory Committee and the California Academy of Physician Assistants Professional Practice Community. She's a dedicated advocate for harm reduction practices and treating the patient as a whole person, and her pronouns are she and her. So, Ariana, I'm really pleased to have you share the stage today, and I'd very much like you to just go ahead and tell us a little bit about what you're doing and what you're thinking, and let's introduce the topic. So, the mic is yours.
All right, perfect. Thank you so much, Carmen. So I really appreciate this opportunity to be here and to speak to so many people. And what I have to tell you is I was probably just like you about 5, 6 years ago. So I am a PA. I work in an emergency department, actually in rural Northern California. It's called Placerville, but some people say it's Placer-Tucky. It's in, it's far away. It's about 45 minutes away from Sacramento. It's in the foothills. We serve a very largely rural population. Some places may only be 15 miles away, but because of, different geographic issues with mountains, et cetera, windy roads, it can take 45 minutes to an hour for folks to get to my emergency department. So what I did 5 or 6 years ago, I didn't think was unusual or special. I started looking at what to do for the overdose epidemic that was plaguing our community. And we started by decreasing opioid prescribing, right? That's what I thought was appropriate. So if there's a flood, if there's a flood in the house and the faucet's on, turn off the faucet. So that's where I started with all of this. I was trying to turn off the faucet. So how could we be more mindful about opioid prescribing? And then I asked a question, and I don't know if anybody on this call has ever asked a question and then thought, uh-oh. I said, well, what are we doing if we identify opioid use disorder? What are we doing about folks now who are struggling with opioids? And it was crickets. Nobody had an answer. And I was working in a hospital where I thought, how could we not have an answer to that? And so I started giving buprenorphine in my emergency department. And then I got together with others who were doing the same. There was a small amount of us. I thought that was unusual. And then I became more and more impassioned. I really started becoming, I was shocked at how little capacity there was. And so I set out to increase capacity and in my rural community, but also in the state. And actually the executive director of my program has said, we now have 85% of hospitals in California who are giving buprenorphine, just like we started doing 5 years ago. And people have said, Well, how did you do that? And the simple answer is we always believed we could. So now we're doing harm reduction, and we've really been able to be nimble and quick in our response to fentanyl because of the work we started doing in our emergency departments 5 years ago. So that's who I am. And again, I just simply made the decision to do the right thing, to meet people where they're at and provide care for folks who needed it. And that has changed what we do in our emergency department and what I really believe we could do across our country. So thank you again for your attention and all of the love. I can see the emojis. It's great. Thank you. And I'll go on telling what it is. What is the thing? And let's talk a little bit more about fentanyl. I do want to tell you that I am one of the co-founders and co-principal investigators of California Bridge. California Bridge is a program of the Public Health Institute. We are funded largely by the Department of Healthcare Services. We have grant funding, and I work for them. That's my only disclosure. I don't have any other no disclosures other than I am one of the co-founders and co-PIs of California Bridge. So let's talk about fentanyl. So fentanyl has made a lot of news, right? And for good reason. It is really causing this huge surge in overdose deaths. So I can tell you, if you had asked me 5 or 6 years ago if there's a problem with opioid use disorder in my county, I would have said no. I had no idea. I thought, yeah, we've overprescribed opioids, but we'll just turn off the faucet, everything will be fine. I didn't know there was as much opioid use disorder issues in my county because I wasn't making it safe for people to tell me about this, right? We didn't change our language. We didn't meet people where they're at. So I think a lot of people were afraid to talk to a generalist like myself, somebody who works in an emergency department, about fentanyl use. But when we look at the statistics, we can see that there was a period of course, we all know there's overprescribing of opioids. And I was a part of that. I've been practicing since 1999. So I have been a part of that, and I have to own that. And yet I can tell you that I knew we could do better, and I wanted to own it and do something about it. So I saw that there was a second surge in heroin overdoses right around the time we figured out, I think there's a problem with opioids. And then what we've been seeing for quite some time now is this big surge. And when you look at all of the graphs, you see this big increase in overdose deaths that are largely related to fentanyl. So once we had fentanyl in our drug supply, we saw this huge surge in overdose deaths. So let's talk about fentanyl. So what is the deal with fentanyl? So fentanyl is a synthetic opioid. I've been using it for years to control pain, and I was always under the assumption that it was short acting. But I'll talk a little bit about the pharmacology, especially with what we're seeing in our communities with street fentanyl. But we certainly know that fentanyl is very strong, and as it's an effective pain reliever. There's lab designed, fentanyl. We see a lot of street fentanyl now, and there is some unpredictability in the supply. So fentanyl has a very high affinity for the mu receptor, and you get this higher high. So people tend to use often. They tend to smoke it every 2 hours. These are what all of my patients are telling me and what we see across the country. It doesn't show up on drug screens reliably. So I know I don't require drug screens to give medication for opioid use disorder or mood in my emergency department. But what I can tell you is when I do send off some drug screens, when we've had overdoses, when we have somebody who's curious, we see fentanyl in almost everything now. But in the emergency department drug screens, we aren't able to detect fentanyl. And the other thing that's a little different about fentanyl is that it can build up in fat stores. So it takes a longer period of time to go through withdrawal. Though folks are used to using a pretty high, I mean, you can talk to your patients, but they are typically using a high amount pretty frequently, like every 2 hours. So it's not uncommon for folks when they first stop using to experience a lot of anxiety, agitation, but it's just important to differentiate that from withdrawal. So this is a changing epidemic, right? So it's no longer prescription epidemic. That changed a while ago. And if it was that easy where we could just turn off that faucet, like I said, and we would just reduce overdose deaths, great. But what I can tell you happened when we have been turning that faucet down, we have been turning that faucet off in some cases. So what happened? So when we did not fill capacity in treatment at the same time that faucet was being turned off, we saw this big gap in care. And what filled that gap? I mean, it's largely been fentanyl and methamphetamine. That's what we're seeing fill that gap. I personally want us to fill that gap with treatment, with harm reduction, with hope, with options for patients. So that's what we need to do in order to turn this around. But let's talk about a little bit about when we see fentanyl. So first of all, just assume fentanyl. I can tell you, I was just telling Carmen, I remember I was trying to tell a patient, hey, you need to be careful. There's fentanyl out there. This was actually in 2020. It took a little longer for fentanyl to really arrive in my rural town. But I remember in early 2020, I was talking to somebody who was using methamphetamine, came in for an abscess, and I was talking to him about his use, and in a caring, compassionate way, offering harm reduction. And I said, well, hey, do you want some fentanyl test strips? Because there's fentanyl out there. There's fentanyl, and sometimes it could be, is your methamphetamine contaminated with fentanyl? And he said, oh, no. I like fentanyl. Fentanyl makes my high better. And I thought, oh, it really, at the time, it was giving me a better education in this, because I thought people wouldn't use fentanyl intentionally. But no, he told me that it was actually a good high for him. So I gave him a lot of naloxone. I gave him some safe smoking kits, and told him that we are available for treatment. But I remember that was a turning point for me, where I realized people are now choosing fentanyl. This isn't a fentanyl poisoning issue. Sometimes it is, and we'll talk a little bit about that, but people are choosing to use fentanyl. So why would they choose to use fentanyl, right? Well, it's cheaper, it's easier for them to carry, it's easy for folks to smoke. Again, folks have told me that they like that high because it crosses the blood-brain barrier really quickly. So we'll dig into that a little bit. But what I can tell you is, when do we see fentanyl? Assume fentanyl. In what we have seen is, yes, heroin. I was just saying, I just had somebody who told me she was in the black, she was using black tar heroin, and thought it would be pretty easy to come off of heroin, and we were getting her on buprenorphine. She was asking for treatment. She had been using for 40 years. So this is somebody who had been using for a very long time. And I did send a drug screen just to see, and actually fentanyl showed up. So she did not realize she was using fentanyl at that time either. You can assume fentanyl if somebody's buying, the Perk 30s, when people are buying Percocet off the street, any Norcos off the street, we are finding by and large that is fentanyl. We do find some fentanyl contamination in meth and cocaine. And then again, there's intentional use. In my community also, I have folks who believe that they're taking a benzodiazepine, like they'll say, I'm using Xanny bars on the street. And we have also found that is fentanyl when that has been tested. So let's talk a little bit more about what's the deal with fentanyl. So fentanyl, again, is more potent. So it is about 25 to 40 times the potency of heroin, 50 to 100 times the potency of morphine. So this is a potent opioid, and it has a pretty narrow, therapeutic window, but it's very lipophilic. And so it has a high volume of distribution. So there's this, it rapidly crosses the blood-brain barrier. It's rapidly distributed into adipose tissue. And then it has this slow dissociation. So that's what we're seeing. And, you can see distribution time about 1.7 minutes, redistribution about 13 minutes. And then the elimination half-life is about 3 to 5 hours. So it has a short half-life after a bolus. And that's what I've been doing in my emergency department for years. But it does, again, because of those lipophilic properties, there's also decreased renal clearance. So it sticks around longer in terms of going into withdrawal. So urine toxicology may be positive for more than 7 days, actually, if you're doing your UTOXs. So one of the barriers, one of the problems I was going to discuss today in terms of offering folks treatment, hope with fentanyl, is there's a huge amount of misinformation out there. And I'm just hoping that if you get nothing else from today, it's keep calm, offer treatment. Folks deserve rapid, easy access to treatment. And people still can take medications for opioid use disorder, whether it be buprenorphine, methadone. Easy access to treatment is key in this. So yes, we see precipitated withdrawal sometimes, but it's a little deceptive because there's a lot of information that there's just huge amounts of precipitated withdrawal. But my question is it just not adequately treated withdrawal? I can tell you that there's a large NIDA CTN trial going on across the country right now. And preliminary reports are we're not in those studies seeing a huge amount of precipitated withdrawal. It's been less than 5%. And I was sure that I was seeing increased precipitate withdrawal in my emergency department. And I took a look, we're actually treating more patients now. And the precipitated withdrawal rate in my emergency department was still only 1% to 2%. But what do we talk about all the time? The 1% to 2% of precipitated withdrawal cases. So they tend to get a lot of press. A lot of people talk about them, but the rates of precipitated withdrawal are not going up. So let's talk, what is precipitated withdrawal? So when we give, so again, I said that fentanyl has this really high affinity for the mu receptor. The medication that we give, and for the most part, I'm going to talk about buprenorphine and methadone. So I know that there's only about 36% of folks who are actively treating people who use fentanyl, but I just want everybody to know that medications work. So in its simplicity, what I can tell you is the medications decrease a person with opioid use disorder, a person's risk of dying from any cause by more than 50%. So 10 times decreased risk of dying from any cause if somebody is on medications for opioid use disorder. If somebody has been in treatment and then is not in treatment anymore, their risk goes up like 2.5 times the risk of death. So when we are talking about medications for opioid use disorder, methadone and buprenorphine. And for me, most of the time in this talk, I'm going to talk about buprenorphine because I can easily administer that in my emergency department. I also work at an FQHC. This is what happens when you work in a rural town. I work in the emergency department and I'm a PA, so I can work in different settings. I work in an FQHC sometimes and also provide outpatient treatment. And I'm working on trying to work in a rural health center, like a bridge clinic outpatient as well. So again, I'm typically giving buprenorphine because I am able to prescribe it. I have my X waiver, but even if I didn't, I could give it in my emergency department. So again, treating with buprenorphine. Buprenorphine has a very high affinity for the mu receptor, higher than fentanyl. So what happens is what precipitated withdrawal is, if we gave buprenorphine and somebody was not quite in withdrawal enough from fentanyl use, it would bump off the fentanyl. And buprenorphine is what we call a partial opioid agonist. So it's not as potent as the fentanyl. So then what happens is there's this gap between full agonist, partial agonist, and that space in between is what we call precipitated withdrawal. So precipitated withdrawal is something where if you gave buprenorphine to a patient, they would very rapidly, very quickly, it's like this immediate withdrawal symptoms. And what does withdrawal look like? This is what I always see: sweaty forehead, dilated pupils, goose flesh skin, yawning. I never knew that yawning was a part of withdrawal. And I used to think that people were being dismissive. That was part of my own stigma. But yawning is a part of withdrawal. Runny nose, watery eyes, nausea, vomiting, diarrhea. So also there's anxiety and agitation that can be a part of it. But the difference between undertreated withdrawal and precipitated withdrawal is undertreated withdrawal is kind of this gradual worsening, which I've seen when we haven't been giving, kind of replacing with adequate enough amounts of buprenorphine. And precipitated withdrawal is this sudden, it's like, boom, somebody is in withdrawal. So how much of an issue is precipitated withdrawal? Again, less than 5%, probably more like 1% of patients experience precipitated withdrawal, but there's not great quantitative information on any increase in precipitated withdrawal right now. We are increasing capacity numbers of people we're treating. I have seen more precipitated withdrawal recently than I ever did before. But so it seems like it's more, but dose of buprenorphine does matter in this. And so again, enter buprenorphine, which is what we're giving in our emergency department. This is what I'm able to prescribe from the FQHC. And this is, by the way, in my FQHC, it's all primary care physicians, PAs, nurse practitioners who do this work. So if you're out there and saying, well, I don't have any specialists in my community, any addiction specialists, it's okay. I started this as an emergency department PA in my community, so you can do this. But what I can tell you is when we give buprenorphine, the two things about buprenorphine that I love that make me feel really good about giving this is, number one, it has a high affinity for the mu receptor, so it outcompetes other things. So yes, it can cause precipitated withdrawal, but it also is really sticky on that receptor. So if I can load somebody with buprenorphine in a safe way, in a way that makes them feel better, and let's say they found some heroin, fentanyl in their sock drawer and they used, the buprenorphine actually is really tightly bound to that receptor. So typically those other medications don't work. And the biggest part is the buprenorphine has a ceiling effect on respiratory depression. How do people die from overdose? Is they stop breathing. So when I give them buprenorphine, I created the safety profile because they have a tightly bound medication that's going to keep them from stopping breathing if they did use fentanyl. So really, really important here. Now that there are some caveats to that. So if somebody is using benzos with buprenorphine, they can be tricky. That's when we can run into some problems. But for the most part, like I said, buprenorphine is a very safe medication, and I would certainly suggest advocating for this. Or if you're on this and don't have your X waiver, it takes 5 minutes. It's free. Get your X waiver today. Start prescribing buprenorphine. If you're in an emergency department, you can administer it for up to 72 hours without it. So there's my pitch. But the other thing I want to talk about is, again, the risk reduction when we are giving buprenorphine. So giving a medication that is sublingual, dissolves in the mouth, works in about 15 to 30 minutes, peaks at 1 hour, is really sticky to that receptor, lasts for 36 to 48 hours, depending on the dose, up to 72 hours sometimes, and reduces that person's risk of dying from any cause by more than 50%. This is something that we should all be advocating for, and we should all be doing. So in the age of fentanyl, how do we address starting somebody on buprenorphine? So a couple of just little pearls here is just wait. If the person can wait for bad withdrawal, just do your standard start. I have a person who was using heroin before, more recently was using fentanyl, said he knew exactly what it needs to feel like to start buprenorphine because he had taken buprenorphine before. And I said, right on, here's your prescription. He was going to start in a couple of days. Great. It went really well. If somebody is afraid to, like there's a lot of information that everybody's going to precipitate withdrawal, which again is not true. But if somebody has a lot of anxiety, then there are some people who cross taper over to buprenorphine, and there's lots of algorithms available online. I tend to have a problem with this. I don't do this from the emergency department setting. I do meet people where they're at. I'll tell them where, I'll give them supportive medications, and I try to get buprenorphine on board as soon as possible. In the hospital setting, I cross taper from full agonist to buprenorphine by giving tiny doses at first, just to start taking over that receptor, and then within 3 to 7 days, get them completely on buprenorphine. So again, and if somebody is overdosed and we've completely reversed them, then great time to load up on buprenorphine. I consider it airway, so I consider this safety. So if it's a standard, single substance opioid overdose. So this was somebody who was using fentanyl, somebody who was clearly using heroin and overdosed, and we've completely reversed them. It's a great time to load them with buprenorphine. So anyway, we have at cabridge.org, we do have a lot of information on this and ways to do this. But so what do I do now? How's my practice changed since that one gentleman told me, oh no, I like fentanyl, I'm using it. And I swear I've seen somebody who was using fentanyl. It's the only thing in my community since that time. So how has that changed my practice? Well, I now look for physical signs of withdrawal. So I used to go more based on the COW score. We've all probably heard of the COW score, COWS. So I still look at that. It's a great way to educate somebody on what withdrawal looks like, but I rely less on any subjective symptoms. So if somebody is feeling anxious or agitated, I don't usually take that into account as much as physical signs. So I'm looking for 2 or 3 physical signs of withdrawal. That's how my practice has changed. And I will sometimes give somebody more buprenorphine than I used to, just to overcome the deficit there. So just to keep it really simple, I won't get into the weeds of treating, but you can go to cabridge.org. We have an algorithm. It works for fentanyl. That's what we do most of the time. Most of the vast majority of the time, these starts go well. I see a lot of people who, like I said, we start them on buprenorphine. It's this wonderful moment where they realize they can take a medication and feel normal, and that this medication is very protective. And we know if we do this in the emergency department, we double a person's likelihood of being in treatment in 1 month. Credit to Gail D'Onofrio for publishing that in JAMA in 2015. But the other thing I want you to know is, so what happens if you do precipitate withdrawal? The thing that we're all afraid of, the reason I believe that we saw this decrease in buprenorphine administrations, when we saw fentanyl, What happens if you precipitate withdrawal? Well, we treat that. So I do want to put the word out there that it's very treatable. So frequently just by giving more bupe. So it's really important. I tell my patients this too. So I also tell my patients, hey, most of the time this goes great. You're going to feel better. But by chance, if it doesn't, it's okay because you're not going to leave my emergency department feeling like this. We can give you medications to treat it. So what do I do if I precipitate withdrawal? I give more bupe initially. I will give some adjuncts. So I will give some supportive medications. And if none of that works, then I have things like I do, just like I take it into a complex pain situation. So if somebody is taking buprenorphine and breaks their arm, we sometimes give them full agonist opioids on top of that. We sometimes give them ketamine to treat their pain. So same idea here. If we precipitate withdrawal, if giving more buprenorphine doesn't work, if giving adjuncts doesn't work, then I take it into a complex pain type of scenario. And more recently, I've given full agonist on top of the buprenorphine, and I've given ketamine. Those two things have worked great. And what I can tell you is even if you precipitate withdrawal and somebody's squirming around and is very agitated and looks miserable, I treat human suffering. I do not like it when I see somebody suffering, but I tell them, we're going to fix this. This is going to get better. And you know what? It does. So if I can get them through that first 12, 18 hours, I mean, I had a lot of folks leave after 2 or 3 hours. When I did a big review of precipitated withdrawals in my own emergency department, I realized that 95% of people went home within about 4 hours. So we gave them a bunch of medication. They may not have felt perfect, but they were like, I'm good. And they stayed on. I have a 92%, between 80 and 92% follow-up rate. They go to continue treatment. So the most important thing is to preserve the relationship with the patient, let them know that you've got their back, you're going to help them, and then help them if you do precipitate withdrawal, and they can get through it. And my patients all feel better the next day. All of them do. So I just have to put that out there. So the other thing is I work in an emergency department. I like to start people on treatment. It makes me feel good. But people can actually start this at home. People are pretty good at this. For especially people who use drugs, I can tell you, they teach me a lot. So a lot of people have had previous experience with buprenorphine. Talk to them about it. A lot of people can self-start on buprenorphine, make this low threshold, meet people where they're at. You can't just generalize one thing for everybody. So have the ability to prescribe it. And please make sure you are prescribing this and allow people to self-start at home too. So in the hospital setting, I tend to do cross tapering. I won't get into that as much here, but there's a lot of different ways to do this. We usually do a 3 to 7 day cross taper by giving full agonists in the hospital and then sneaking on the bupe to the point that in 3 to 7 days they're fully on buprenorphine. So again, my personal approach, there's two different options. Number one, which is what I use most of the time, is I just wait longer than I used to. I talk to people about where they're at in their withdrawal, and then make sure I see 2 to 3 physical signs. My second option is if somebody's really having trouble getting there, making sure that we support their symptoms, sometimes doing these cross tapers, which can be done and which we have information on. So there's a lot of misinformation out there about buprenorphine treatment. What I can tell you, there's an article from Sarah Wakeman, who's a hero, who looked at the impact of fentanyl on buprenorphine treatment and retention and opioid abstinence. And what I can tell you is it's pretty similar. So folks who've been using fentanyl can still get started on buprenorphine, can still stay in treatment. It does work still. So it's really important to know that. And there's, sometimes in order for us to get to the right place, we need to give more. So sometimes we have to give higher doses. So if you're stuck in a dosing protocol that's only giving 2 to 4 milligrams, please advocate for giving higher doses of buprenorphine. It's really important right now. So higher doses really can address this. And right now, fentanyl right now, it's not like it was 20, 40 years ago. We need to make sure we update practices, and you may need to give higher doses of buprenorphine. So typically we're giving 24 milligrams or higher, at least for the first week or two, to folks who have been using fentanyl. And a really great option is injectable buprenorphine as well. So I wanted to put a plug out there for that. So lots of different treatment options out there, but treatment is important. I'm going to talk now a little bit about, so treatment's great. Treatment's not that difficult. I started doing this. I'm a PA. I work in an emergency department. 65% of the people who were treated in my emergency department in the last year were treated by PAs or nurse practitioners from Fast Track. So most of the time, this is not hard. And a lot of the physicians who are picking up the patients, it's still pretty easy medicine, right? We work as a team in my department. And so I just have to tell you, most of the time it goes well. What makes a difference? Stigma is a problem. Stigma is a problem. So what I can tell you, one of the reasons I'm seeing more people right now with opioid use disorder is because they feel safe telling me about it. They were there before. I wasn't recognizing it. Why? Because I didn't make it safe for them. So really important to address stigma in your setting. I'm hoping everybody on this call or on this webinar can say, oh yeah, there's no stigma in my setting. I work on stigma every day. I'm currently going through my whole hospital doing a segment on, I have somebody who's talking about her own lived history, talking about the neurobiology of addiction, talking about what we're doing about it. It's important to have an all hands on deck approach. Stigma is important to address early. So language, I did a language audit. I felt like we were reducing stigma because I simply saw language change in charts. So really important to address stigma. And one thing I can tell you, and this is an analogy I make, let's talk about chest pain. Somebody experiences chest pain, we all know, oh, if I'm experiencing chest pain, pretty reasonable, go to the emergency department, get checked, right? But what if you thought the emergency department, if you went in for chest pain, would, number one, not know how to treat it, number two, make you feel terrible for having chest pain, or maybe all of the decisions in your life that led up to you having chest pain that day, that you would be treated poorly. They may talk about you poorly in front of you. They may give you certain looks. Would you go to the emergency department or hospital with chest pain? No, you wouldn't, right? You probably would not if you didn't think they were going to treat you well, and maybe didn't know how to treat it. So what would happen? Well, we'd see this huge spike in deaths from chest pain related issues. For example, heart attacks, dissections. So I can tell you the mortality rate in the first year after a non-fatal overdose is very similar to the first year after a heart attack. You know what the difference is? These are 25 to 35-year-olds. These are 25 to 35-year-olds who are dying. So please make it safe in your practice, wherever you are, for people to talk about their substance use. And the only way to do that is to change language, is to change your approach to make it safe for folks. There's a lot of information about this, but people first language is really important. And people can sense what you're about by the way you talk to them. So please normalize treatment, normalize harm reduction. Now, I'll talk a little bit about harm reduction, and then I know Carmen has some questions for me, but I just want to touch a little bit on harm reduction. And I would love to hear from Andrea from the Dope Project. But we are practicing harm reduction in my emergency department. So if you come in and you talk to me about your substance use, or you don't, that's okay. I provide naloxone access. You don't have to tell me anything. I have signs all over my emergency department that make it safe for people to talk to me about their substance use, because I tell them we'll treat you, we'll take good care of you. I have signs all over my emergency department saying we have access to Narcan, to naloxone, a life-saving medication. You don't even need to be a patient. You could be the friend or family member of somebody in my emergency department. And we've created a frictionless access to harm reduction supplies. So we've had more than 20 deaths in my community this last year from fentanyl, which is really, really horrible. And I think, man, I could have helped every single one of them. But you know what? We have more than 60 saves from naloxone that we handed out from our emergency department in a rural setting. So could you imagine what this would look like if I didn't provide naloxone? I also give folks access to sterile syringes, to safe smoking kits. If I'm helping somebody with an abscess, I'll talk to them about how they use. Make sure that they have access to HIV, Hep C testing, which we're working on point of care testing in my emergency department. Soon we will have it. Thinking about offering PrEP, think about all of the things. The emergency departments are seeing the people who aren't necessarily in the system already. So you may say, okay, like I don't need my emergency department to do this. I've got this, and maybe you're working at a residential treatment facility. Think of all the people who don't have access to you. That's a lot of the folks we see in our emergency departments. So by engaging with your emergency department, by working on the stigma reduction, by working on an all hands on deck approach to harm reduction access, we can turn the tide of this. I am convinced we can change this. We can turn this around, but it's going to take all of us. There's more than 1,000 people registered for today's webinar. That is so incredibly encouraging. We can do this. We can change this around, but it takes all of us. So I've connected with my school board. We have naloxone in every school now. We're providing reasonable education to folks. We're getting over, there's a lot of sensationalistic information out there right now about fentanyl. Educate folks in your community about the real stuff, that this is treatable, that this is here to stay. I mean, honestly, this is a drug that's easy for people to access, and it's very powerful and it's inexpensive. And then making sure that people know that there is hope, there is treatment, there is harm reduction. And again, connect with folks in your own community so you can provide access to that. Treatment is harm reduction. So Carmen, any questions? I haven't been able to look at the chat.
Oh, we only have a few, like 50 questions. Um, and I think that is just incredible. So let's go ahead and get into some. The one that came up very early, and I think it's a really important one to answer. And you didn't really talk a lot about Narcan, but I'd like you to just answer this one question so that we can put it to bed. Is there any harm to unborn babies when administering Narcan?
No. Yeah, so naloxone is incredibly important. Goodness gracious. So this is a very safe medication. In fact, in my schools, a lot of teachers were, we've made naloxone access really easy. Librarians are giving it in our communities. So, I mean, what's worse is respiratory depression, is not breathing, is not getting adequate, oxygen. So naloxone is incredibly important, and we need to make access really easy. So I guess I can tell you, naloxone is the antagonist to opioids, and really important to have easy naloxone access. So I know that there's a lot of people from different states. What I can tell you in California, that we have just our Department of Healthcare Services has an entire naloxone distribution project. And thank you for reminding me to talk about this, Carmen. What we did is we made this easy in our hospitals to give out. I talked a little bit about what that looked like at my own hospital, but by doing this over the last year, and I'm going to give credit to Josh Leftig, he's a PA, he's one of the co-founders of California Bridge, and he has been working, him and Charles Hawthorne, I'll give plugs to, have a lot, I mean, they have saved so many lives in California. How? They're making it really easy to give out. We had our California Department of Public Health, the Department of Healthcare Services, and the California Board of Pharmacy all get together to say that hospitals can give this out. So kind of getting through a lot of red tape, a lot of gray areas, they just all came together and said, please give naloxone in your emergency departments. And anybody can give it. It's like you watch an 11-minute video that's provided that teaches you how to educate others on how to administer naloxone. And it's easy, it's a nasal spray. That's what we're using in California. We let folks know, please call 911 if you need to use that. That's really important. Rescue breaths if you're able, and it works in 2 or 3 minutes, and you may need to repeat it. You don't need to give, there's a lot of misinformation about naloxone. Naloxone still works for fentanyl overdoses. So please have access to naloxone. Naloxone works great for fentanyl overdoses. Have there been people who have given more? Of course, but most of the time we're just seeing that the administration of naloxone is just, 2 minutes can feel like forever if you're reversing an overdose, but really easy to administer. It's a nasal spray. There's clear instructions on the packaging, and through the work at California hospitals, we have now crossed the 100,000 mark. We have given more than 100,000 naloxone kits to people through emergency departments and hospitals in California. So if you're in a state and you're looking at how do I increase capacity for giving naloxone, just like I said, emergency departments and hospitals, we are typically seeing folks who other people aren't seeing, people who don't have access to treatment. Please develop easy ways to distribute naloxone. Make sure it gets into the hands of family and friends of people who use drugs, right? You don't reverse yourself with naloxone if you overdose. It needs to be clear that that's why we want naloxone out there. And if you're having crucial conversations in your community, and there's a lot of people who are afraid of naloxone, let them know that they could, we have AEDs all over the place, and naloxone's a lot less expensive to have, and we have a lot of lives saved from naloxone access. So please make it an easy, no barrier approach to naloxone access.
Yeah, that's a really important point. And the other thing I want to just point out to people, this isn't necessarily naloxone, but we did include several really important references in the chat. So download those, because that's the start of your, of your library, or it's an enrichment to the library you already have. There's some great information here. I want to make sure people don't overlook that. Um, uh, Ariana, do you feel like you have any experience with or any thoughts about the overdose prevention centers and what their how it's working out to have overdose prevention centers? Is that within things that you're thinking about or things that you're observing right now?
I don't have much experience with prevention centers. Can you expand on that a little bit for me, just to make sure I get it right?
Well, actually, if you don't, we'll pitch that to in our harm reduction session,
Yeah.
because I want to keep things in
Oh,
your experience.
I think I know what you're talking. Yeah, if we're talking about safe supply and things like
Yes.
that, yeah, that's actually incredibly. I mean, it's very evidence based. So, I wish we had more access. I know that there's a lot more of this in Canada. We haven't had any deaths from folks in in these opioid or overdose prevention centers, and so I'd be a big proponent. It's funny, sometimes people say, "Did this person use drugs in our bathroom in the hospital?" I'm like, well, it's clean and we're an emergent. I mean, like these things happen, and we're people who can reverse overdoses here. So just talk to people. But certainly I am an advocate for safe supply and access to life-saving treatment. So yeah.
So there's a couple of questions about that I'm going to sort of loop together that seem that they're asking about whether there are any safe drugs that are not contaminated with fentanyl, or
Of
if,
course.
yeah, right. Are there safe? Can any drug be laced with fentanyl? Should you assume that there's the potential of fentanyl when somebody comes in and says that they've taken something they don't know what it is? How
Yeah.
important is fentanyl in keeping that in your mind when you encounter somebody who says that they've taken something?
Well, number one, of course, there's a lot of drugs out there with no fentanyl in them, and a really great way to check is we had didn't even mention this. Sorry, fentanyl test strips. We hand out fentanyl test strips with very easy to use information. For a methamphetamine, you have to dilute it. So you have to dilute it more, or else you get a lot of false positives with methamphetamine. But I give instructions to my patients about how to test their drugs for fentanyl. I would love actually to have a machine. There's these machines out there where you can actually people could analyze their drugs. I absolutely believe that folks should be informed consumers. So if I could get one of those machines, if we could afford it in my hospital, I'd have it, or put it somewhere safe where somebody felt they could test their drugs and make sure that it's safe. So yeah, of course there's, I have people who have trusted dealers. I have people who use drugs and talk to me about it, and certainly use drugs without fentanyl. And there are people who are using safe drugs out there. One story I want to add here, Carmen, is this recently happened. Is there was there was there's some concentrated marijuana out there. There's marijuana wax, and so we've seen some folks who used this wax for the first time, and it looked like a fentanyl overdose, except they were breathing. So naloxone was used on them, and they actually kind of got a little bit better. Why? Probably because somebody was shoving something up their nose. If I'm just honest, we did find that there was no fentanyl in their system, but it was perfectly fine to administer them some naloxone, and just know that it was just really concentrated marijuana, more than what they were used to, and they were very high. So there was not there was a lot of misinformation out there about a lot of things right now. So we're not finding a ton of fentanyl in marijuana, but there can be. I just always say assume fentanyl, but also having folks who are informed is really important. So providing harm reduction supplies like fentanyl test strips can be great. And I wish we got all of those, mass spectrometers or those machines out there, so that people could test their own drugs and make it really accessible to people.
So let me just go back and underscore a little bit talk about how safe naloxone is. So if you have somebody, you encounter somebody and you have some, you happen to be a concerned person and you have some naloxone in your purse and you see that they're not breathing and they're not looking good, what's the harm in giving them naloxone?
So the only harm I see is if somebody was on chronic pain medications and had never been in withdrawal, you administered naloxone, you would put them in withdrawal right away. Uh, Honestly, if somebody didn't, we tell people what to look for, right? If somebody stops breathing or doesn't have adequate respirations, in fact, I wish this were actually placed into our BLS, ACLS protocols that naloxone should be considered, because this is a life-saving medication that is very, very safe. You're not going to go wrong with this. Like I said, it takes somebody else to administer it. So it's really important to make people feel safe administering this. And like I said, the way I usually talk about this is we have librarians across the country who have educated themselves on naloxone and have administered. In fact, I read an article, gosh, there was this one librarian who administered it multiple times, saved so many lives in her community. So, anybody can give this. We just need to make sure it is like flood the community with naloxone. It is extremely safe. You are not going to go wrong. And again, if somebody is not breathing, unresponsive, and you call 911, of course, but this is a very reasonable thing to do. In addition to rescue breathing, if they're not breathing, check for a pulse, etc.
So there was another question here. If you don't test for fentanyl, how do you know that drug is in the system to treat it? Let me turn that around a little bit and say, how important is it to know that you have fentanyl when you encounter somebody?
That's a great question. So, so when we start buprenorphine in our emergency department setting, we don't test people. We do no drug testing. Why? Because number one, fentanyl doesn't show up in our drug testing. And even if it did, it's really not going to tell me if that person is in withdrawal or not. So again, I said that it can show up, their urine toxicology may be positive for I think it was like 7.3 days, but they still may be in enough withdrawal to treat with buprenorphine. So I let folks, I will send it out for testing if they want to know. I had a patient recently who actually, she was using methamphetamine and tested her drug for fentanyl, and she actually felt weird. She used it, felt really weird, and then tested it for fentanyl and figured out it had some fentanyl in it. So, we see folks all the time. It's just really, it doesn't, you don't need to drug test people though for this. We just assume fentanyl, treat early, treat with a low barrier, treat at the right time, but low barrier approach, low threshold approach, let folks start buprenorphine at home. But I don't make any starts on buprenorphine relying on drug testing from the emergency department or from an acute care setting. We get drug testing in the outpatient setting just to have a conversation. So it's used as a conversation. And we've been wrong sometimes on some of the drug screens. I've seen the send-outs and it's not always perfect. So I guess the big takeaway there is you don't need drug testing in order to get somebody started on buprenorphine. That's not necessarily a helpful thing. And we certainly don't make any buprenorphine starts contingent on people using other drugs either. What is more dangerous than somebody using fentanyl and benzo? Fentanyl and benzo is incredibly dangerous. So it's much safer if that person is on buprenorphine, and then we can engage them in talking to them about the benzo use.
So here's a slightly different question. When you first started giving bupe in the ED, were there concerns about how to connect patients to follow-up care, or was there hesitance because of the possibility that patients would come back maybe 3 days later in the absence of follow-up? Talk about that a little bit.
Thank you, Carmen. I'm just gonna be honest, I started from a place of stigma. I said all of the things that most of the people are thinking, and I didn't know I had stigma. So I set out on a path to get to do the right thing. And I encourage other people to do that. But what I can tell you is I was so focused on that follow-up piece. I said, we're not going to give this unless we have certain follow-up afterwards, because we're so afraid of seeing these folks back. I don't require that for any other medical problem. That being said, what I can tell you is the follow-up rate from my institution has consistently been more than 80%. And we have no addiction specialists or people, addiction psychiatrists in my entire community. I have some primary care and emergency department folks who have took their boards for addiction medicine. But It's still important to give the right medication at the right time, no matter what. If somebody came in and was in congestive heart failure, I'm not going to not give them Lasix because they are furosemide because they didn't have follow-up. I'm still going to give them the right medication at the right time. That being said, 258 emergency departments in California, we've never run into a hospital that we couldn't find follow-up. Doesn't have to be perfect. You don't have to have an A+ program to begin with. Just connect with a primary. I started my program with one primary care physician who got their X waiver. That's how I started my program. Now we have 4 clinics giving buprenorphine. So the other thing is, I can tell you, when the emergency department hospital take this on, they make it safe for the rest of the community to do the right thing. So you don't have to have perfect follow-up to begin with, but hey, telemedicine, whatever you can do to get this treatment started is incredibly important. And I am sure you can find something today. That being said, don't not do the right thing. If you don't have perfect follow-up, build it. You can build it, make some calls. We, again, have found somewhere for everyone in every community. And then what we do is take a quality improvement approach after that. And then we see how we can drive better care. And when we do this, we've actually really brought up the level of care in the community too, because we found, hey, if we're seeing, I always say the emergency department's a fishbowl. Everybody's looking in and we're looking out. We see everything, right? So if we see that folks maybe are not getting the kind of care that they need, then we see what we can do to fix that. So we talk about appropriate care and we drive that from the hospital setting.
That's excellent. So we have time for just one minute. Can you just talk about the difference between buprenorphine and methadone? Just what
Sure.
is better?
Oh, well, it's not better. It's whatever a patient wants. It's what they have access to. So methadone's been around forever and is saving lives everywhere. And so in my community, I don't give much methadone because my clinic, it's like a satellite clinic and people have to go every day. A lot of the folks I'm treating just can't. Transportation's an issue. They'd have to go up to a clinic, an hour away once a week. So it hasn't been realistic in my setting. But if you have a great methadone clinic in your area, awesome. So we do have actually a resource at cabridge.org on how to start somebody on methadone from the emergency department. Here, big secret. It's 30 milligrams. You just give them 30 milligrams and get them started and then connect them with a methadone clinic. So really, I guess in the end, Carmen, it's all about patient-centered care. This whole talk, it's patient-centered care. Talk to your patients. Tell them that they have options. The difference between methadone and buprenorphine, both are considered medications for opioid use disorder. It's just, methadone is more tightly regulated, so more difficult to access in some settings. But my partner Hannah works in San Francisco. They have great methadone access and great retention and treatment with methadone there, and so that's a great option for her there. So I just give buprenorphine in the emergency department setting. I like its safety profile. I like that it has that high affinity for the mu receptor. I like the ceiling effect on respiratory depression. I don't have that with methadone. That being said, methadone has a ton of evidence and it works, it saves lives. And when I quote that that buprenorphine reduces a person's risk of dying from any cause by more than 50%, it's actually methadone. Methadone has really outstanding numbers in terms of decreased mortality. So I'm a fan of what works for a patient as long as it's evidence-based, and both methadone and buprenorphine are evidence-based.
So I've really loved this, Ariana. We have 84 questions. And as you know, we'd never get to 84 questions, but we will definitely use your questions and use your feedback to create the next series of webinars. So don't feel if your question did not get answered that we didn't see it and that we will not be trying our best to provide the kind of information that you need in order to answer those questions. So I want to just give a big shout out to Ariana for all the work that she's been doing. Remind everybody that many of the resources that she's talked about are available on the Bridge website, which is cabridge.org. So please go to that website and download whatever you need. And also on the page where you registered for this webinar, we have other resources that are available for you. I want to remind everybody that we are also hosting the Overdose Prevention Leadership Summit, which is going to be on the 6th and 7th of December. One of our featured presenters is Nora Volkow, who's the director of the National Institute on Drug Abuse at the National Institutes of Health. And again, go to our website. You can find a link to that, and please register. We think it's going to be a fantastic event. Next slide, please. Please let us know what we can do to support you. So contact us at nopn.org. @ariana.org/contact. And we absolutely want to hear, what do you need to know about? And how can we help you in your efforts to prevent overdose deaths and really save lives? Thanks so much to everybody for attending. It's really been a fantastic session. And thank you again, Ariana, for being part of this conversation.
Thank you so much. This has been really fun. Thank you, Carmen.